Metadent Educational Group.
Hello everyone, in this video we're going to describe a really common situation in women known as PCOS. PCOS stands for Polycystic Ovary Syndrome. But before getting into details, at first of all we have to get familiar with some basics of female reproductive system. At first of all we have to know how does it work, and then we're going to come into details of this really common situation in women known as PCOS. So here in the embryology, we have a really common word known as follicle, that sometimes it's mistaken with follicular cells. So what's the difference between follicle and follicular cells? In fact, in the ovaries of the fetus, we can see some kind of structures known as follicles. But these follicles itself composed of two components. The first one is ovocytes and the second one is follicular cells. So if I want to draw you some drawings, imagine that this is the ovocyte. This is the ovocytic component, and around this ovocyte we can see accumulation of cells, and these cells are known as follicular cells. And these follicular cells have different kind of functions, and in general they provide support for the ovocytic component. And these small cells around the ovocytes are known as follicular cells. And as you know, as you studied in the embryology, we have different types of follicles. For example, primordial follicle, primary, secondary, tertiary, and finally the mature Graafian follicle. And the question is why we have different types of follicles. So the answer is based on the level of development of these follicular cells and this ovocyte. We give different names to this follicle. For example, primordial follicle. If I want to give you some example, primordial follicle. What's the characteristics of primordial follicle? At first, ovocytic component. The ovocytic component here is primary oocytes and the follicular cell. The follicular cells are forming some kind of squamous-shaped appearance structure around these primary oocytes. And these two components with each other form primordial follicle. The next one is, for example, primary follicle. So what will happen in the primary follicle? The thing that happens is that the oocytic component is still primary oocytes, but the follicular cells starts to grow and their shape changes from squamous appearance to cuboidal appearance. So if I want to draw you something, it's like, sorry for my bad paintings, but they form some kind of structures like this. See, their appearance changes from simple squamous to simple cuboidal. It's like these cells have grown and they form these structures, and these are known as primary follicles. So the primordial follicle changes into primary follicle, and etc. We have secondary follicle, tertiary follicle, and at the end we have the mature follicle known as mature Graafian follicle. So another point that you have to take into account is that when the fetus is in the uterus, the only follicles that are formed and we can see in the ovaries is these primordial follicles. Never we can see a primary, secondary, tertiary, or even mature Graafian follicle in the ovaries of the fetus. All follicles that are present in that time is primordial follicles. And in different references, you can see different numbers, but in general, if I want to tell you, about 5 to 7 million of these primordial follicles are formed in the ovaries of fetus, and when the fetus is born, only 1 million of these primordial follicles remain. But it's not all, and the fetus starts to grow, and when they reach to puberty at the age of like about 13, 14 approximately, only the person has about 400,000 primordial follicle. And each month, one of these primordial follicles starts to grow up and change into primary, then secondary, tertiary, and finally mature Graafian follicle. And finally, they do ovulation, that now we're going to describe it. So getting to this diagram that we have here, as you can see here, we have different concentration of hormones, FSH, LH, estrogen, and progesterone here. So when the person comes to puberty, the effect of estrogen and progesterone is getting much significant. So as you can see here, we have considered a period of like sexual developments in female as 28 days. So as you can see here, at the beginning of these 28 period, the concentration of estrogen and progesterone is so low. So the thing that happening here is that these low concentrations of estrogen and progesterones give negative feedback. Pay attention to this word, negative feedback, to pituitary gland. And pituitary gland, in response to these low concentrations of estrogen and progesterone, starts to secrete two important hormones. The first one is FSH, and the second one is LH, follicle stimulating hormone, and the second one is luteinizing hormone. But the thing is that the effect of FSH in the first half of period is much more significant than LH. As we can see, in the second half of the period, for example, from day 14 to 28, the effect of LH, luteinizing hormone, becomes more significant than FSH. In general, in the first half of the period, FSH plays the major role in the sexual characteristics that we will describe here. So, okay, the FSH and LH will increase, will secrete into blood, and so that's why here we can see the concentration of FSH and LH has significantly increased. So what is the effect of this FSH here? FSH comes and affects these follicular cells around these ovocytes on the primordial follicle, and FSH stimulates them to grow and get more mature. And these follicular cells, in response to the effect of FSH, they start to secrete a really important hormone known as estrogens. So that's why approximately after 3 to 4 days, in different references it's different, but approximately about 3 days after the start of new cycle, we can see that the estrogen concentration is getting high. Yes, and these estrogens are secreted by the follicular cells in the ovaries. And as you can see here, the estrogen and progesterone at the beginning of the menstruation cycle is so low. So that's why at the first days of this period, the menstruation takes place. We can see uterine bleedings in women. Why this happens? Because these two hormones, estrogen and progesterone, are really significant in uterus. When these hormones are absent, the endometrium becomes unstable, and that's why we can see bleeding from the uterus. So, but after that, when the concentration of estrogen gets much high, we can see the bleeding is not going to take place anymore. Yes, it's because of the effect of estrogen. And estrogen is secreted by these follicular cells more and more and more, and finally, at the day of 13, we can see maximum concentration of estrogen in the blood. Okay, we said that at the beginning of this period, we can see negative feedback on the pituitary gland, but when the estrogen concentration gets much high at the day of 13 approximately, now it gives positive feedback on the pituitary gland. So what will happen? It causes the secretion of FSH and LH. Again, we can see LH and FSH has been secreted into blood again. So that's why here we can see LH surge here, this black line, at the day of 14, approximately about 24 to 35 hours later. From the peak of estrogen concentration, we can see LH surge here. And this LH surge cause three main events in female body. The first one is it causes the primary ovocytes change into secondary ovocytes, and as a consequence, so imagine that this is the primary ovocytes, and they are already arrested in the prophase of first meiosis, and with the effect of LH, they complete their first meiosis and they change into two cells. And these cells are known as secondary ovocytes. And this is the first polar bodies. And these known as ovum. But in general, we call both of them as secondary ovocytes. This is the first event that takes place because of the effect of LH. The second thing that happens here is that this LH causes ovulation. At the day of 14 approximately, the primordial follicle has changed into primary, the primary has changed to secondary, secondary to tertiary, and tertiary to mature Graafian follicle. So at the bottom line, at the day of 14, we have mature Graafian follicle. In the mature Graafian follicle, we can see ovum that is adjacent to first polar body, and around these secondary ovocytes, we can see accumulation of follicular cells. And because of the effect of LH, we can see ovulation. So in the ovulation, the follicle is ruptured, and the cells is released into fallopian tubes. This process is known as ovulation. And after ovulation, also some follicular cells still remain in the ovaries, and these remnants of follicular cells in the ovaries, by the effect of LH, they change into a structure known as corpus luteum. The corpus luteum in the second half of the period starts to secrete two main hormones. The first one is estrogen and the second one is progesterone. The progesterone, as you can see here, its concentration is getting high, and also here. And we also can see the maximum concentration of progesterone and also here estrogen at the day of 21. And literally after the day 21, the corpus luteum starts to degenerate, and that's why after the day of 21, the concentration of progesterone and estrogen gets low. And when the concentration of these hormones get low, what will happen? Again, a new period will takes place. We can see the bleeding of menstruation here. So these are the basics about female reproductive system. Let's dive into details of PCOS. It can have different causes like obesity, chronic high concentration of luteinizing hormone, insulin resistance, and of course genetic predispositions can prone the person to PCOS. At first of all, I want to tell you about chronic high concentration of luteinizing hormone. When we examine the ovaries in the patients with PCOS, with ultrasound of course, we can see multiple great follicles with big size are present in the ovaries at the same time, and this is abnormal. But the thing is that none of them tends to do ovulation. None of them want to release the ovum into fallopian tubes. Now we want to know why this condition happens. Come here. As I told you, for ovulation we need what? We need high concentration of luteinizing hormone. But here we have a high concentration of luteinizing hormone for chronic time, for long period of time, but ovulation doesn't take place. Why? Because for ovulation we need two criteria. The first one is high concentration of LH, but the second one is fluctuation of LH. What does it mean, fluctuation? It means we need, LH concentration comes up, then goes down. It is known as fluctuations. We need both of them at the same time. But here we only have the first criteria. We only have high concentration of luteinizing hormone, but we don't have fluctuation. Fluctuation doesn't take place here in this situation. So that's why ovulation doesn't take place. And we can see multiple follicles in the ovaries that don't have tendency to do ovulation. And another reason that high concentration of luteinizing hormone can cause PCOS is that these LH stimulate PCOS cells. What are PCOS cells? In fact, imagine that this is a follicle. Around them, we can see some kind of cells known as PCOS cells in purple I drew. And these PCOS cells start to produce some hormones known as androgens. Androgens, when they are secreted by the PCOS cells in high concentration, they stop follicle from getting mature. So that's why here in this situation we can see a lot of follicles that they apparently have been arrested in their growth, and they don't have tendency to do ovulation. And what more? And by the way, androgens are chemical components like testosterone or dihydrotestosterones, DHT. That's how chronic high concentration of luteinizing hormone can cause PCOS. Another one is obesity. What will happen in obesity? It seems that, of course, its main reasons is still unknown, but it seems that according to studies, it seems that when the patient has obesity, they are insensitive to insulin. And when the patient is insensitive to insulin, the pancreatic beta cells starts to secrete more insulin. Why? Because they want the effect of insulin. But the patient unfortunately has insulin resistance, insensitivity. That's why pancreas starts to release more insulin into the bloodstream, and we can see high concentration of insulin. Then, when the insulin is secreted into bloodstream, again, it stimulates the PCOS cells to secrete androgens. And when we can see high concentrations of androgens, as I told you before, it can lead to PCOS. And in fact, it's the same things that happens in obese patients. And if I want to explain these two conditions in details, in obese patients, when we have high concentrations of androgens, because these patients have high amounts of fat tissues, adipose tissues, these androgens are converted into estrogens type 1, E1, also known as estrone. And whenever that we have high concentration of estrogen in the bloodstream, this hormone stimulates different cells to proliferate. And of course, when we have uncontrolled cell proliferation, what will happen? We can see formation of cancer. So in obese patients, when they have PCOS, we can see high risk of cancer. Normally, the ratio of E1 to E2 is 1 to 2, of course. But in obese patients, the ratio becomes to 2, 1. E1 and E2 are different form of estrogen that we can see in patients, and of course in the future they will have some kind of complications like endometrial cancers or ovarian cancers. Yes, and about insulin resistance, as I told you, they increase the secretion of androgens by the PCOS cells, and of course it leads to PCOS. And one of the complications of PCOS is hirsutism that we will describe in the video. And signs of insulin resistance is acanthosis nigra. What is acanthosis nigra? It is a condition when we can see hyperpigmentation of the skin on areas such as neck or armpit skin. These can indicate the insulin resistance in the patient. So if you have a patient with dark pigmented skin in the regions like neck or armpit, of course we have to do lab investigations to rule out this insulin resistance. For example, with oral glucose tolerance test, you have to measure the concentration of glucose in the blood to know if the patient has this condition, insulin resistance, or not. And another complication of this PCOS, especially in the insulin resistance people, is anovulation. As I told you, we can see multiple follicles in the ovaries, but none of them tends to do ovulation. And when ovulation doesn't take place, of course, we will not have any female gametes, and of course, no fertilization will take place. Other complications are like amenorrhea, oligomenorrhea, or menometrorrhagia. All of these can be seen in these patients. And because in these patients, no corpus luteum will form. Why? Because no ovulation takes place. Because no corpus luteum is formed, we can see low concentration of sexual hormones like progesterones. And when the progesterone is low, the risk of abortion in these patients is much high. And how we can recognize them in these patients? We can do a lab test known as SHBG, sex hormone binding globulins. Whenever that the concentrations of insulin or androgens also is increased in the bloodstream, they have negative feedback on SHBG synthesis. So in these patients, when they have high insulin, it causes the low concentration of SHBG. Sex hormone binding globulins are proteins that bind into sex hormones in the bloodstream, and that's why when the insulin is increased, or even androgen, they are increased, they give negative feedback on SHBG synthesis, and of course we can see low concentration of SHBG. As I told you, to rule out insulin resistance in these patients, we can do blood glucose tests like OGTT, oral glucose tolerance tests, and the results are abnormal due to insulin resistance. These are the points that we have to describe here. And we have Rotterdam criteria to diagnose PCOS. We have 3 criteria here, and 2 out of 3 of these criteria should be present to have provisional diagnosis, not definitive, provisional diagnosis about PCOS. The first criteria is a high concentration of androgens, either by biochemistry or by manifestations. What does it mean, biochemistry? Biochemistry, it means that the patient have high androgen concentrations in blood. This condition also known as hyperandrogenemia. Yes, and also on the manifestations, these high concentrations of androgens can lead to some manifestations such as hirsutism. What is this hirsutism? In fact, in patients with PCOS in women, these women have a lot of hairs on their skins, on the back, on the hands, and these are not just normal hairs, but they are really thick hairs on the body. Why it happens? It is because high concentration of androgens in blood that leads to these clinical manifestations. The second criteria that should be present is ovulatory dysfunction, as I told you, because these follicles don't want to do ovulation. We can see amenorrhea. What does it mean, amenorrhea? It means the patient doesn't have menses. It is known as amenorrhea. Or oligomenorrheas, it means it has, but the duration between uterus bleedings is much high, approximately is greater than 35 days each period. On ultrasound also we can see on both or one of the ovaries more than or equal to 12 follicles, and these follicles, their size is less than 1 centimeters, or according to some references it's something between 2 to 9 millimeters, or the volume of ovary is more than 10 cc. And as I told you, 2 of these 3 criteria must be present to establish your diagnosis about PCOS, but take this into account that these are provisional criteria, not definitive criteria. And complications, the most common cause of hirsutism and anovulation is PCOS. As I told you, hirsutism will happen because of high concentration of androgens. Anovulation and anovulation is also because of high concentrations of androgens, or maybe because of high concentrations of luteinizing hormone, and etc. I describe you this pathogenesis. You can see TK cells hypertrophy, TK cells by the effect of either by insulin or either by chronic effect of luteinizing hormone. They start to become hypertroph, and in response to this hypertrophy, they start to secrete high concentrations of androgens. So in these patients with the PCOS, we can see the concentration of androgens is something between 70 to 200 nanograms per deciliter. And as I told you, when the androgens are secreted by these TK cells, they arrest the growth of the follicle. And that's why we can see multiple follicles with arrested growth. And here in this situation, we can't see any dominant follicle. Of course, when we don't have any dominant follicle, we can't see ovulation. This is a condition known as anovulation. And also hirsutism, as I told you, occurs due to mildly elevated androgens. And the concentration of androgens is between 70 to 200 nanograms per deciliter. We can see growth of hairs in male pattern on the chins, on the skins, exactly same as males. And appearance of acne are present, and these acne they don't respond to usual treatment, and after a while they change to scarring acne. It means the remnant of these acne will remain forever. And alopecia sometimes can be present in these patients. Alopecia means loss of hairs, and especially on the head. And here we have realization that this is a complication of PCOS. What will happen in realization? It means the female will have characteristics of a male, and these characteristics are more prominent than in conditions such as hirsutism. So when this realization takes place, when the concentration of androgens is more than 200 nanograms per deciliter. So as you know, besides ovaries and testes in males, we have adrenal glands, and in adrenal glands we can see production of androgens. So if the female has like tumors, like androgen producing tumors of ovary, or late onset congenital adrenal hyperplasia, of course in this situation we can see high concentration of androgens. So as a result, we can see clitoromegaly, in which the size of clitoris is more than 1 centimeter. And also we can see increase in muscle mass, deepening of voice, also breast atrophy, and temporal recession of hairline. That's it. And here is a diagram about causes of hirsutism. As you can see here, the most common cause is PCOS. Other cause is idiopathic. We don't know why these conditions will happen. The third one is congenital adrenal hyperplasia, a condition in which adrenal glands are hypertrophed. Its cells are really active, so they start to secrete more concentrations of androgens in the bloodstream. And the last one is androgen secreting ovarian tumors. So if you have a patient, female patient, with the signs of hirsutism, it can have all these causes. How you can recognize what is the cause of this hirsutism in this patient? So the investigation that you have to do is, at first of all, as the first step, you have to assess testosterone level. If the concentration of androgens like testosterone was between 70 to 200 nanograms per deciliter, we say, okay, it is possibly PCOS, Polycystic Ovarian Syndrome. Why? Because I told you, in the PCOS, the concentration of androgens is something between 70 to 200 nanograms per deciliter. If the concentration of androgens was normal, maybe it is idiopathic hirsutism. You have to do more investigations to rule out its causes. But if the concentration of androgens was more than 200 nanograms per deciliter, plus some signs were present like clitoromegaly, it can have the patient can has like tumors, like congenital, like for example androgen secreting ovarian tumors, or it can has congenital adrenal hyperplasia. In these situations, we can see that the concentration of androgens is much more than 200 nanograms per deciliter, as I told you here. So that's it. These are the basics about PCOS and how to recognize them.